Hey, hello friends. I am Dr. Vijay Deshmukh from India. I'm presently director of ICDRO Dental Implant Institute based in Pune, which is a non-profit organization, and we are into implant training for last 12 13 years. I'm full-time into practice at Smilex as a chief implantologist. I am founder of ICDRO and founder of Journal of ICDRO. I've been teaching to various dental colleges before for almost 21 years, and now I'm into full time practice and I teach implantology to many practitioners throughout India. So, this is where I am based. Now, all friends from all parts of the globe are on this beautiful webinar, and this is a wonderful platform. So all senior implantologists which are teaching for last 2 3 decades, this is an interesting time for all of us, that it's so easy to reach to all parts of the globe with the help of technology, with the help of webinars. I am sitting here in Pune, and globally we are all connected in this global crisis time. So friends, wherever you are, be safe, be comfortable, be happy with your family. This is the time to learn new skills. This is the time to conserve energy. This is the time to make plans for the future, and definitely we'll all have a very good future. So I'm based in Pune. It's the west coast of India, around 100 miles from Mumbai, and my city is an historic city. So you can see we have historic monuments in Pune. This is a famous fort called Shanivarwada. Then we have palaces, and Pune is all surrounded by beautiful, serene valleys and mountains. And this is very beautiful in rainy times. So Pune is transforming into a big metropolitan city. We have 6 universities and we have 5,000 IT companies based in Pune. So Pune is a very huge city, a population of around 10 million people are staying in this beautiful city. This is my family. This is my beautiful family. She's my daughter Shirley. So last year she graduated from US. My son Vedant, who is into the high schools, and my beautiful wife Sonali. She is orthodontist and head of Department of Orthodontics at Pune University. So this is my family, and this is my B&B family. So I am very thankful to B&B family. I'm very thankful to Banzi family, Dr. Claudia Banzi, Simone Banzi, all Banzi brothers, Mani Krishnan here, who is a distributor for India, LA is here, Simone is here, and then this is a beautiful time when you hosted us when we were touring Italy in the beautiful time of December, and this was a wonderful meeting. Those who were present those days, these were mesmerizing times, and the icing on the cake was the snowfall at Bologna. So thank you Bologna, thank you BNB, and my friend Ionis who introduced me to BNB family. Thank you very much, and thank you LA for having this webinar from my experience to all my friends all over India. So webinars are interesting and a very good platform to share the experience. So these are my three initiatives. Smilex is my brand, which gives specialty dental care. This is our institute, which gives implant training in India, and this is my journal, which is into 12th year of publication. So my background into implantology goes way, way back almost 30 years. Almost 30 years I've been associated with implant learning and teaching and practicing various aspects and various milestones for 30 years. So 1990 I started, and we were a group of founding implantologists in India, in Mumbai, and then we started a small group in 1990 in India. During my post-graduation 1991, I did one dissertation on endogenous dental implants, and then subsequently got the hands-on in 1993. So, related to our today's webinar topic, that is immediate implant placement and loading, my first Fraley 2 implant case happened in 1998, and 2005 we did first immediate implant placement. So today's topic of webinar is how to maximize success in immediate implant placement and loading, right? So we all are doing implantology, and we all reach to a success rate of 95-96%. And after that, from 96 to make it 100%, case after case, and having aesthetic success, having functional success for a decade or 2 decade. This all what basically I'm going to share from my experience. We never had opportunity to learn implantology the way today it is available. Webinars, workshops, dental schools are teaching implantology, and possibly every way you can learn implantology. But in those days, it was very difficult. So whatever we had gathered out of experience, I'm going to share with you, all my dear friends. So we all want two things in life, right? So we want two things in life. First is success, right? We all want to be successful in life, and the second is the happiness, right? So today definitely I'm not talking on happiness. Sometime I do get into motivational times, and I do motivate my friends on happiness, how to be happy all the time. But today we are going to talk about how to achieve success. So three things will make our life successful, right? Three things, general three things, right? Basic three things. First is the knowledge. We should have right knowledge of what we deliver in our day-to-day practice. Secondly, we need to keep on learning new skills, right? In this modern time, we have to keep on honing new and new skills every day. And the third is the right use of the technology. Right technology and right use, both things are important. So three things are make you a successful implantologist. Then there are three concepts in implantology. We'll not go deep into the first one, that is a delayed implant placement, which is given in 1965 by Dr. Benamack and his group. Then immediate implant placement was given in 1976 by Schultz and Himke, and then Liederman in 1979 told that immediate implant loading is a possible. So three eventual concepts are there in implantology. So what is delayed implant placement is basically been well published. I don't want to go much detail into it, but is one of the most successful and most predictable treatment what has been suggested by the literature. So, but there are limitations of delayed implant placement protocol, right? So we can't wait in modern times and then lose a lot of vertical and horizontal bone. Like we know that if we wait after extraction, we are going to lose a lot of vertical and horizontal bone. Then loss of gingival architecture, and I'm being periodontist, I'm really keen that we should have white and pink aesthetics. Our aesthetic score has to be accurate and very nice. Then loss of function of mastication is the most important. Now today, patients don't want to wait that long, which in the back days, old days, they used to wait. And loss of confidence due to compromised smiles. We all want to have a beautiful smile all the time. And prolonged period 4 to 6 months, right? So who wants to wait that long? So this is a simple case, but you can see all these characteristics. What has happened with the delayed implant placement has happened here. So we have a bone atrophy, we lost the tissue, and we lost the whole topography of this area, right? So it has led to a bone atrophy, right? So we have just 2 millimeter of crestal bone, and then it becomes a limiting factor that how to place an implant in 2 millimeter of crestal bone. But this type of situation happens to our clinic every day. So what is the choice? What is the choice is either to go for crystotomy or GBR, right? So we can always do a sausage technique and then expand the bone laterally, horizontal bone expansion. But in this patient, now patient is 60 plus years, and definitely I want simple solution. I am minimalistic person and I want to simplify things in my practice. I want to give very simple things to the patients, and that makes the life very easy because post-operative complications are less. So we had gone with a very simple protocol, and then we got with initiating drills, and we always use stoppers like last 25, 27 years of practice. Stoppers been always the part of my practice, and this is how we place the Duravit 3P B&B implant. Right, so we have been fortunate to introduce B&B in our practice last year, and I'm very happy that all our results are fantastic. Right, so this is an implant of choice in this procedure, and majority, my 90% of application goes with 3P implants because of the fantastic implant, progressive tapered implant thread. So these progressive threads are very important to give me the primary stability and better control of implant placement. So this is very nice implant whenever we have situations like this, and definitely supported by technology from Ferrari and this more taper and what connects the technology. This is all helping basically to get the increase the success rate from 96% to 98% to almost 100% situation. So this is all simple to implant placement in delayed situation, and this is how we place the peak abutments and healing, and this is after 3 months, exactly after 3 months, and we are ready to take the impression and load the implant. So this is a perfect platform switch what we had achieved in this implant prosthesis, and lovely prosthesis, and this is a beautiful occlusal anatomy of the bridge. Right, so this is how you see a nice implant been supported by the bone all over the implant, and very nice aesthetic results. But today's seminar, this webinar is basically about 90% of my implant practice, and that topic is immediate implant placement. Right, so it's a very interesting topic and very good topic to boost our practice. We all are clinicians. We all want to deliver the best to our patients. We want to have optimum 99% success rate in our practice, and that's what basically the literature also gives us support, right? So we have the literature support from Dr. Schul's early publications, and the placement of an implant immediately after tooth extraction offer the advantage of treatment time reduction and potentially increases patient satisfaction and aesthetic outcome. This is very important. All the practitioners, all the clinicians who are into high-end practice, we want the patient to be very satisfied, and we want aesthetic results to be outstanding all the time. So, right, so immediate implant placement is can change your practice the way we had done before. So this another publication, immediate implant surgery, 3 years retrospective study of 50 cases was published, and this study concluded that this study provides a survival rate of 98% of implant in 3 year follow, right? So, and they had said it's 98% success rate. That's brilliant, beautiful, right? So then we have a publication by Dr. N.P. Lang, right? So Journal of Clinical Oral Implant Research. He says immediate implant placement is a well accepted treatment modality, and that has shown to have high cumulative survival rate of 92 to 100% depending upon the placement of the implant and the different parts of the oral cavity. So what are the advantages of immediate implant placement? My dear friends, we always move with the advantages whenever a new technology, new implant system, anything new comes, and we want to go and do that thing. So we look for advantages. So here are advantages for immediate implant placement. One, procedure to extract, place implant, graft, and place the gingiva form. Right. So three procedures are minimized. Three procedures are minimized, and we are going with least amount of anesthesia, no less pricking, less antibiotics, less painkiller to the patient. Third advantage is saves month of treatment time, right? So important in today's time that we should save patients time, so patient time is money, our practice time is money, the preparation time is also reduced, right? So it saves a lot of time, maintains gingiva and the bone architecture. So this is very important. I am periodontist and I always look implant perspective of an implant aesthetics. So my majority of work in implant and aesthetic zone, I look for a very stable soft tissue around the implant. Right. So and then we want high acceptability by the patient. So patient like it. One procedure and you are doing everything. So they like it. So that is why it becomes. So why don't many of the people don't do this? What is the reason why don't do they? Because number one, they need to be very automatic, right? So they need to be very automatic to the tissue. They should not damage soft tissue. They should not do too much of bone expansion. They should not break the bone plates around the tooth. Then they need to learn debridement of the tissue. So a lot of people they just extract the tooth and don't do the debridement. So here you have to do debridement. Need very good precision to place implant in a 3D position, right? So it's very important, right? So need very good precision to place implant in 3D position, right? So you need to learn how to place an implant when you got a big extraction socket. Need very good implant planning and need good anticipation of bone remodeling. Five success criteria. What are the success criteria we should look for? Type of alveolar socket, so classification of extraction socket by Alien and what he has suggested, right? So if we got something like this, it is called type 1 socket, right? So what is a type 1 socket is we have intact labial cortical plate and the intact soft tissue. So this is an ideal time when you can extract a tooth and place the implant. This is ideal type 1 socket. What is a type 2 socket? What is a type 2 socket? When you have a marginal crestal bone loss of the buccal cortical plate. That's the time we have to be worried, but in this case, type 2 socket, your soft tissue is intact. So we can place implant and do GBR. Then type 3 socket is the socket where you have lost the buccal bone, you have lost the soft tissue, both things. Then you have to always understand that there are two types of bitypes and thick type and the thin type. So thick bitypes are always the best situation when we can place the implant, and thin bitypes you have to be always careful, right? So you have to be always careful about the type of need of modification of the biotype, and you can always go for connective tissue placement. So when we started doing immediate implant placement more than 2 decades before, this was the A position when we used to place an implant in this socket, right? After extraction, this huge socket we used to even sometimes place 5.5 millimeter of implant, right? But today in the aesthetic zone, our implant is not more than 4 millimeter anytime. So we have moved from position A to position B. So we are placing implant very much towards the palatal side and not in the center of the socket. So this is in last 2 decades what we can see the change from A position to the B position. And the third, use of perfect implant. All implants have different macro anatomy, so we have to understand that implant need to be ideal for the ideal situations. Use perfect drilling protocol, use expanders, use ideal diameter of the length of the implant which has the best thread designs, gives us very good success rate. Right, so there are two school of thoughts in the world, so there are a lot of clinicians who are going for partial extraction or what we have socket shield techniques. To my practice of almost more than 25 years into regeneration, I always very comfortable with the bone graft material. So I always do dual zone grafting over to the socket shield techniques, and that works very well to my hands and in my practice. So as per the studies, it has already shown that we can achieve 2 to 2.5 millimeter of bone. We can have always uh, regenerate, or we can always have a 2 to 2.5 millimeter of bony counters from the buccal side, and we can also modify the biotype if you need to do connective tissue grafting. So let's go with the cases like about the immediate implant placement. So I divide the situation. So I just go for immediate implant placement. See the torque. If the torque is more than 45, and if the patient has already consented that they want immediate implant loading, then I go for loading. Otherwise, it is extraction and the placement of the implant. So, which happens eventually 8 cases in 10, we go for extraction and immediate implant placement. Whether it is anterior, whether it is posterior, we go that with that routine. And only 2 out of 10 situations we go for loading. So this patient in 1998 has lost the tooth, and here the patient demanded that can you do something like that? Can you extract the remaining root and place a implant in the socket? So we don't had much of literature in 1998 about immediate implant placement. So in my practice, this has happened, and then patient wanted that can you deliver, you can extract the root and place the implant at the same time, right? So we told the patient give us 3 days time, and then we schedule the patient. So we extracted and then place the implant at the same time. These are old wide, I think 5.5 millimeter wide Fralit 2 implants. So in early 90s, we were all knowing the concept of wider the implant, better it is. But today we are into aesthetic zone and we want better and better. So we place the implant exactly in the socket. Today I may not do that, right? And then we out of basically logical thinking, we again place the gingiva former, and then we sutured it, right? So this is implant has been placed, and this is a gingiva former, and then we just sutured it. So beautiful X-ray shows implant with the gingiva former, right? So this is a logical treatment plan. What we did in those 1998, beautiful soft tissue profile after 4 months, and then this is a metal coping trial of PFM and the perfect aesthetics. What you can see, very nice aesthetics in 1998 with just a PFM crown. Today we have gone to CAD/CAM crowns, but in those days we had to believe in a good laboratory which can give nice crowns. This is the implant aesthetics in 1998. Right, so we go for another case. Let's go move ahead 7 years, 2005. These implants also I'm not practicing now. These are old cases just for review. Right, so lost the bridge, we extracted, and then without a flap, opening the flap, flapless implant placement has been done. You can see complete socket has been occupied by the implant, right? So there is no question of loss of the labial cortical plate, and the implants has been placed subcrestal, and we can see 3 implants. So 1 implant and this 2 implant, 3 implant in place, and this is what you can see. The bridge has been given from the tooth number 21 to 24, and this is how you see 2015 follow. The bridge is intact, beautiful placement, and then we had already placed 3 implants by doing crystal sinus grafting, and this is very stable, right? And this patient after 15 years, right? So by the time we had placed 1 more implants and 1 more implant at the back, so 2020, this is how the smile is. So it's a very stable results. We can see a very stable soft tissue. Right, so then again one more case in the aesthetic zone. This is 2015 case again, right? So just 5 years before what we were doing. So similar case, patient has lost this crown, patient had this external root resorption here, patient has perforation here, and this crown was moving. So we extracted those 3, and then what we can see, we have beautiful type 1 socket. The labial socket is intact. Here also labial bone is intact. Beautiful bone, we curate, right? And the lateral incisor, we are type 3 socket, means we don't have buccal cortical plate here. Right, so we feel that this is not an ideal place for immediate implant placement. So we decided to place 1 implant here, 1 implant here, and then just give 1 cantilever here. Right, so this is how we had extracted and placed or curated and then placed two implants immediately. And this is continuous suturing, and we approximate. This is very important, that if we open the flap, we need to close it perfectly. If we close perfectly, healing is most of the time is absolutely without any problem. And this is beautiful temporization with the Maryland bridge. So here we had given a Maryland bridge to the patient, and from the canine to canine we had taken the support. So after 4 months, what we see a beautiful stabilized soft tissue, and these are the beautiful zirconia crowns 2015, right? So they are subgingival crowns, and this is cantilever, and this crown is separate crowns which is not fixed to the implant. We never join implant with the natural teeth, so this bridge is separate and this crown is separate. And then this is at the time of cementation, and this is after 1 year. This is after 1 year. And beautiful implant aesthetics in 2015. Right, so you can all appreciate that if you take care of soft tissues, you are going to get beautiful results, and absolutely patients are very thankful for such kind of results. Now let's go back to 2019. So this is the last year case when the patient reported us that he has lost a crown on the old root canal treated tooth, and you can see. So we decided to go for immediate implant placement. So we always open a micro flap. I'm not in favor of flapless. I always open a micro flap. And I'm being periodontist, I'm very comfortable to see the crystal bone. I'm very comfortable to manipulate the papillas, and I know to bring back them where we want. Rather, in today's time, with the kind of peak abutments we are having with B&B, possibly we can achieve migration of the tissues, which I will show. So we always open a microflap. After debridement, we decided to place the implant. So this is beautiful position of the implant exactly between the two lost roots after curating. And this is the old implant 10 years before, and this implants we decided always use stopper, right? So there is no question, right? So whether you are doing after 7,000 implant, 10,000 implant, we are still doing using stopper, and that is very comfortable. So really BNB stoppers are top class, and they really help in the success of the implantology. So this is an B&B Duravit implant. This is fantastic implant what we had used here. So this is intraradicular implant placement, and as you finally ratchet into the final position, definitely that is going to be subcrestal. Slight amount of break of this bone is going to happen, and that is absolutely perfect. No need to worry for that. But we could achieve, in even such a situation, could achieve around 45 Newton centimeter of torque. And this is the peak abutment, which is really we are enjoying in India. Thank you BNB for this beautiful innovation to the implantology, and this has made our work so easy. Now we place implant, we place this peak abutment, and really within 3 months the case is ready for taking the impression. After placing the peak abutment, we then graft the area. This is xenograft. We had grafted, and then suture, right? So bring back the tissue where they belong to, and this is beautiful results what we can see after a week. After 3 months, it's ready. Just call. The best thing about this peak abutment, they never get loose, so as compared to many other abutments, they get loose after 1 month. So here this abutment never get loose, and that's really comfortable feeling for every clinician. So this is beautiful soft tissue healing around the B&B implant. And then this pickup cap is amazing, and that makes precision for the laboratory to go ahead and place their components, and we are ready to put the crown. So this is full zirconia crown, full contour zirconia crown. And this is a perfect implant and the crown. So what better we can do in today's time? This is amazing. So a simple case, but if we do with precision, the success goes very high. That's my philosophy. I don't believe in doing major bigger thing like zygoma implant, but I would always want a small thing, but if we do it very nicely, and if we can give a high predictability, if we can do minimalistic trauma, these things work for decades to the patient. So this is another case with B&B implants. This is why I said it's a critical case. This is a very critical case because of the kind of anatomy we got. We are at the floor of the sinus, very fragile tooth, and this patient is an old patient. She's in early 60s, and she says, "Doctor, I don't want to extract many teeth. I don't want too many implants. I don't want sinus grafting here. So can you give a simple solution?" I said, fantastic. We will augment the bone, do vertical bone regeneration here. We'll place one immediate implant here and give you bridge and the crown. And patient was very happy. When we simplify things to the patient like it. When we make it complex, they really don't like it and they take a lot of time to decide the treatment plan. So this is after opening the flap. That's why you can see that it's a very critical situation everywhere, but we were very positive in such a critical bone situation. When we have D4 quality bone, I always use in posterior maxilla bone expanders, and that changes the way we get the success, right? So this is the Lederman drill, and then directly we go with the bone expander. So this is the Lederman drill because we need to go very precise, and we don't want to go into this periapical area. We want to bypass this area. So we just moved from this laterally. The beauty of this drill is it cuts laterally. So that's what I like, Lederman drill. And then we just go went laterally, and this is how we change the angulation of our initial drill. And then we had used the bone expander. This is a lovely expander, and in such a situation, only with the apical one-third of the expander being in the bone, we could get around 50 newton centimeter of torque. So I like bone expander in my practice now. This is a new addition to our practice, B&B bone expanders in the kit, and this is an implant which we placed 4 by 14. So implant is subcrestal. Again, we are going to do grafting here. So we place the PICC abutment and then go for the grafting all around the implant as well as the posterior side. And then suture it well, right? So approximation is the key. If you want good results, learn very good suturing, so don't be underconfident. Always try to be more, and then that helps in long term. This is beautiful implant placement, subcrestal, and this is how we had given the bridge, and this is an implant crown, right? So this is an implant crown at the time of cementation. So we are waiting for this patient, and we want to see after 1 year whether what has happened to this papilla. But I am absolutely sure that this papilla must have filled by the same patient. Lower arch, again we had a compromise, only 2 millimeter of alveolar crest. Just 2 millimeter of bone is there. That's it. Right, so we have 2 millimeter of alveolar crest. So again we had gone for crestotomy and not GBR because patient is 60 plus. Right, so we are gone for 2 millimeter of crestotomy here. Around 1.5 millimeter of crestotomy. We place one implant here and one place implant in the back. And again use a bone expander. This is 4 by 10 and this is 3.5 by 10, and this beautiful two implants got 40-45 newton centimeter of torque. So I always believe in initial torque, which gives me a very good feel, so that is more than enough for getting an idea that these implants are going to work for a long time, right? And then grafting and then suturing. This is after 4 months. Again, the same protocol. We take impression, and then this beautiful one-piece zirconia monolithic bridge with nice subgingival placement, right? And this is what you can see, perfect angulation, and the bridge has been cemented. Right, so let's go for another case. Right, so this is one of the amazing case. Last year we did it, and really beautiful results has come, and I'm happy to share with you. The patient lost this bridge, and we what we can have a carious 1.5. This is a problem now, and the patient wanted a very predictable. Patient is a CEO of a big multinational company, and he wants a very predictable. So I said, "Okay, let's go one by one, and then we will have separate crowns for every tooth." And after opening the microflap, that is the reason I opened the microflap, because I'm a periodontist and I know a lot of things happens below the marginal gingiva, and always we will not have the architecture like this. We'll have architecture which is modified. So always open a small microflap, absolutely no problem, so that you can do an implant placement in the right position. So expanders, right? And then what we can see, a 4.5 by 10 B&B implants, right? So absolutely ideal implant placement, absolutely ideal implant placement with a 45 to 50 Newton centimeter of torque, right? So then we place the peak abutment, and what we have around 3 millimeter of buccal jumping gap, right? So we are going to augment, and we just don't augment, we press the graft inside the socket, right? In this such a situation, we need to graft, we need to put a lot of graft material. And here what you can see, the beautiful graft all around the implant position is absolutely perfect, and then we suture it out, right? So this is extraction, and this is after 45 minutes, right? So we are in the sinus. Yes, my dear, we are done sinus lift, but not the grafting. So we are around 1.5 millimeter implant is in the sinus, and this is the bicortical stabilization also. This particular floor of the sinus is giving the maximum support to this implant. And after 3 months, this is what you see, beautiful migration of marginal gingiva. So from here, so we have around 3 millimeter of marginal gingiva migration on the peak abutment. So this is really motivating for a periodontist when he sees something like this. So when we look at the literature, we realize that the peak material is back to static, and that is what basically helping migration of marginal tissues, and that is giving wonderful results. So in subsequent cases, when you see, you are going to see the beautiful results by this abutment, and that this is, I think, the perfect addition what I think the B&B implants have. And this is the emergence profile what we today want in each and every case, and we are fortunate that this case has given absolutely textbook perfect emergence profile. So beautiful stippling, very soft tissue is very nicely healed, and this is what we can see after 4 months. So last case today, what I will show, so this has happened in the last case, similar to this has happened to last case in the 5 days, right? So I will show that is that my last case today's presentation. So today we are going to see a lot of implants because we are in a shutdown time. We are at homes. We are missing our dentistry. We are missing our tooth, saliva, blood. So today you have a lot of exposure of implants, so that whatever hunger of implant is there, that will be fulfilled. So that's why I taken maximum cases. Many cases I wanted to take further, but there is a limitation of time. So my dear friends, let's watch more further. So this is how we compress with the crown and then go for the cementation. So it's little shorter, but my crown is little subgingival, it's okay. And but this is fantastic implant aesthetics. So this is what the patient loves, and this is what the patient get ideal implant aesthetics in the posterior area, and they are very happy with it. Now, one more advanced periodontitis case. I am being periodontist, so in the older days, possibly we'll treat with something complicated called flap surgery. But today, implant success rate is so high, we don't go for any compromises. We are extracted these teeth and then place implants. So after extraction, what you see, we have very nice thick biotype, right? So even though we had done an flapless extraction, but we are going to open the flap, right? So always open the flap to see the perfect anatomy of the remaining bone, and then you can decide where to place the implant. So this patient was not willing for too much of expenditure, so we decided to place two implant, one implant here and the one implant in this position, and to make a 5 unit of bridge on two implants, right? So this is possible when you got beautiful implant system like B&B, when we got expanders, right? So we placed longer implants. These are 4 by 14. We placed, this is a buccal bone, this is a buccal bone, and you can see that we are almost to 2 millimeters subcrestal, right? So we have placed the implants subcrestal and then grafted the whole sockets and then sutured it well, right? So it's very important. We should bring back the tissue where they belong to. It's very important. And this is the implant positions. And this is after 3 to 4 months time, you see beautiful healing. This is what you see, the very stabilized result around the implant. Some particles of graft are still there, that's all right, they will get washed out. Absolutely don't worry about them. Rather, to my observation, this bone material absolutely stabilizes the soft tissues for very long time. And this is what you see, the pic, and then you pick up the impression, send to the laboratory, and you get a 5 unit of bridge on just two implants, right? So this is the bridge what we cemented on the tooth, right? So this is one of the most critical case what I encompassed till now, so she was a young patient of 31, high smile line, chronic periodontitis, collapsed buccal bone, and very demanding husband, right? So she was a demanding patient, had a periodontitis everywhere, and what we can see in the bone, we have resorption of the anterior roots, right? So we wanted to place four implants in this area, but we have challenge. What is the challenge? We have 1.6 millimeter of bone in the asthma region. This is the region which is more going to be very critical. We may start placing the implant here, but in this area our implants are going to expose, right? So we have 1.6 millimeter of bone in this region, and that is going to be critical factor. So this is the situation. We have 1.6 millimeter of bone. It's impossible to split this thing, so we decided to we'll go for implant placement, and we'll do guided bone regeneration at the same time, right? So we started doing scaling and then root planing, remove the crown, and then the grafting and temporization, and then we opened the flap. We did flap surgery, as well as at the same time we did implant placement. So you can see the amount of calculus presence. So the kind of hygiene was neglected in the past. Then we placed four implants by after going for 2 millimeter, 3.5 millimeter bone expander, and the bone expanders gives fantastic primary stability, and these are absolutely simple. So we placed Duravit Slim 3 by 12 two implants, and 3.5 by 10 two implants. So these are the subcrestal implant placement. So we finished the implant placement, and we were knowing that these implants are going to expose from this side, so we are not much worried at the time. Just place the implant. So we placed the implant, and we were knowing that this implant is going to expose somewhat here. We went ahead with the guided bone regeneration. So we have been very comfortable doing guided bone regeneration for almost 25 years now. So this is absolutely routine procedure. And on the other side also, we had augmented and placed the membrane. Okay, so beautifully going subperiosteally, you can snug the membrane below the periosteum, and then roll the membrane on the periosteum of this flap, right? So it's possible, just takes little time. So I don't use tags most of the time. Absolutely, I'm comfortable placing the membrane below the flap, and it is possible. You just need to learn the manipulation, and this is how we do the approximation of the flap and bring back the tissue where they belong to, and the healing is going to be very, very comfortable, right? So these are the four implants. So then the patient goes off with the temporary crowns. So we'll not take much about the prosthetic, and this is what we see the uh, prosthetic what crowns we had given, bridge we had given to the patient on four implants. Beautiful emergence profile, very stable soft tissues around the implant. A beautiful aesthetics. This is before and this is the after smile, right? So patient is very happy, patient's husband is very happy, and absolutely they are very happy with the kind of results this patient has got. Right, so this is simple case. What it looks like that we'll extract a tooth and place an implant, but we lot of time have challenges in this patient. Even though we got a long possibility of a very long implant because we have something around 28 millimeter of bone, but this root was almost touching the labial cortical plate, and that's a problem. So we went ahead. We just separated the tissue with a 11 number blade. Then we did the split the root in between and then subluxated the tooth, right? So it was a long root. We extracted and then we passed the probe to check. So when we pass the probe, we check, oh, there is a small bony perforation. We don't perforate the tissue, we just check with the probe and we could see there is a small perforation and this is the perforation, right? So something like this happens, then definitely it is the time to decide that we are going ahead with guided bone regeneration also, right? So we discussed with the patient and patient was said, absolutely doctor, I have faith on you, go ahead. So we use bone expander, and then this is the beautiful bone expander which has gone absolutely perfect angulation. And then we placed EV implant. These are B&B EV implants, are fantastic implants, and you can get amazing amount of primary stability with these blades. So this is 4 by 14 implants, and this is an ideal 3D position with the EV implants. So we have a nice jumping distance for grafting. This is subcrestal implant placement. This is accurate position what we wanted. We had landed there, and patient don't wanted the immediate loading, and patient has already consented that you can do placement but not the loading. So we grafted and then we placed our membrane and sutured it well. So you just observe the response of this epithelial tissue on the peak abutment. So we sutured it well, brought the tissue on the peak abutment, and then given the Maryland bridge. After 3 months, when the patient, you see the soft tissue remain where it was, right? So we have excess of tissues in this situation, right? So we have papillas where we have excess of tissue, we just do a laser and remove that tissue, and then we go with crown preparation and then the impression, right? And this is how we had, this is our implant crown at the time of cementation, right? So this is a separate crown, this is separate crown, and this is separate crown. So this beautiful result is only possible because we had done a lot of soft tissue consideration. We had selected a perfect implant and then given a perfect result to this patient, right? So let's move to the third segment of today's talk. First we had learned a bit about immediate implant placement. Before that, we just went with the understanding the Brennemark concept of delayed loading. And we go to the third concept, like, so because sometimes patient want immediate loading also, right? So now the demand is increasing from patient. Naturally, if we want to do very scientific implantology, every patient cannot be propus, but some patient definitely. So what is an immediate loading? Immediate is placed, implant is placed, and prosthesis is fitted within the 3 days, and then we can call that as an immediate loading. So biological basis for implant is there because what we are looking at an implant surface, micro and macro designs. So first there is a formation of a fibrin mesh, there is a coagulation, and that is going to help in the migration of the osteogenic cell, which ultimately going to induce the bone growth. So in this particular osteosynthesis time, we need our implants to be stable, and that stability can come with the macro design, the apical threads which are there with the EV implants of B&B. Now, this concept was given by Liederman in 1979, and this of his study basically in the mandible. Liederman was the first to document successful healing of immediate loading of implant in the anterior mandible. And we have subsequent literature reference by Tarnow and Brunsky reported that micromotion can be deleterious at the implant bone interface. So we don't want more than 50 to 100 micromillimeter of forces on the implant, and then the osseointegration can happen. So then subsequently we have seen World Congress consensus in 2002, Barcelona. They scientifically accepted the term IL immediate loading, and immediate loading protocol was accepted for mandibular prosthesis as well as for single tooth and the bridges as an accepted scientific way to restore the patient. Romanov's, my friend George Romanov's study is also a very important study to consider in the literature. He has concluded that 100% implant survival is possible, and his study was on 2 years of prospective clinical study of 12 cases, and which has been published in 2006. So we have a lot of literature support to the understanding that immediate loading can be done. So what is the most important? Most important is the case selection. Very important. We need to select the case perfectly, so we need not to rush and keep on giving the promises to each and every patient, but case selection is very important. Then today single teeth can be replaced, multiple teeth can be replaced. We also replace full arches. What is important? Bone quality as well as the quantity, both are important. Then also important and should be underlined in the consent that patient is ready to take the risk of failure, and he should not claim the doctor has done something. So patients signing a written consent is very important in my practice. I ask them to write the consent and then go for immediate loading. And patient ready to do modification in the chewing habit is absolutely essential. So there are many factors which governs the immediate loading. We must consider the biocompatibility of implant, means the type of implant, macro geometry of the implant surface. Surgical skill is the most important, right? So all clinician lead do some amount of trauma, but we have to do micro trauma to the soft tissue. Then micro motions, what kind of micro motions your immediate loading crown will have. The loading protocol, immediate, delayed, early, what kind of loading protocol, progressive, lingualized, right? So then the bone quality is absolutely important. Bone metabolism is very important, right? So understanding. Then factors going to be very important in the post-operative diet. So you need to write down what not to eat. Then the prosthetic design, occlusal tables are absolutely very important. Whether you want to splint, type of occlusion, and the number of implants are very, very important when you go for full arch implant placement. So 2005, I started with the immediate implant loading. So this is a finished case from 2007 album, right? So this tooth was lost and we decided to place implant. So we went flapless and we place this implant and this abutment. Then we take impression and then send to the laboratory. Laboratory sends us a simple acrylic crown, and then we cement that acrylic crown within 2 or 3 hours time. So this was a 2007 kind of understanding that immediate implant loading is possible, and this is how she looks in 2007. So we have follow-up of our cases. So this is, I think, old case around 12, 13 years now we had done. This lady from US has come to my practice in Pune. She had this failing tooth, already extracted one tooth, and she wanted one implant, and she wanted to save. She was there for just a couple of weeks, and she wanted me to know that if you can deliver an immediate loading. I said we are doing it for very select patient, and if you can give a written consent, we will always go for it. And so we placed implant, and then placed the abutment, and then given a crown which is little flat crown occlusally, and this was done in 2 to 3 weeks time, and patient was very happy that the final prosthesis has been delivered before she could go back to US. So within 3 weeks, the patient walked out with a tooth, and we extracted the last tooth and grafted, and the patient went back. So this is from 2007 case, an implant placement in jaw former loading, 2007, and then we grafted, and this is how the patient comes after a year for follow-up, and we could see that this graft is beautifully stabilized. And then we placed 2009 another implant here, and then this is 2009 we make another bridge, two separate crowns for the patient. 2016 patient comes, and we replace, and we make a joint separate zirconia bridge. So in the whole time of this, what we can see here, the 12 years, the crestal bone is absolutely very stable. So implant immediate loading is possible. So, life philosophy is very important, and our life revolves around the choices. So, every choice we make has the consequences, right? So, in this lockdown time, we all need to decide about good choices in our life, right? So, maintain peace of mind, learn new skills. There are hundreds of new skills we need to learn. So if we make right choices, right consequences, possibly if you want to review your implant kit, you want to learn many things we need to learn now in the coming days, and how do we work after the lockdown is over. So choices and consequences are important. So new designs and concepts. So I'm very happy that I introduced this implant system in my practice. Last year, B&B implants launched in India, and this is an amazing implant. So immediate loading, this is definitely my choice today, because it gives me a perfect kind of an ideal immediate loading protocols, and it's an ideal also in the soft bone, and it gives a great amount of primary stability. Right. So also it has a platform switch. Then it has the connector connection. So I'm really happy with the kind of a moss taper effect what we get. Absolutely, there are no cases of screw loosening. We had forgotten now the screw loosening our practice, and we are really comfortable that this implant has made our practice, and we are changed to a next level into practice. Now we'll just discuss, because of the lack of time, we'll have just two or three cases. This is a tooth which patient lost. This is a canine. And this tooth is really, there are five different clinical challenges here. First is it's a canine, and we all senior people know the canine is difficult to extract. It's further second challenge is we got a implant next to the tooth which is very close. We have challenge number two here is my route is absolutely in the wrong direction. If I go straight, possibly I'm going to perforate here, so I need to change the angulation, right? So that is another second challenge. Challenge 4 is I got a very weak periodontally affected teeth, and patient has told me that nothing should happen to this lateral incisor, so I need to save this. And challenge number 5, we got a gingival recession. So there are 5 challenges associated with this tooth number 2, 3. So first challenge we overcome with Lederman drill, and then we change the angulation here. We change the angulation. So we don't want to go here, we have to go here. And believe me, this is one of the most important step when you are promise the patient that you are going to give the crown, right? So this is how we change the angulation. We go this direction, which is towards the lateral incisor, and then we place an EV implant. So in the beginning, EV implant I used to place with the handpiece, but my instructions to all my friends, EV implants place with only the hand driver and the ratchet. So don't attempt with the motor and handpiece, because you need to go in a precise position, because this implant gives a very high torque, and you just cannot change it. So just place it by hand. So this is freehand implant placement, perfect implant position, jumping gap which is filled with the graft material. And this is an ideal position of B&B EV implant, beautifully grafted, and this is the peak abutment also fixed. Right, so this is a fantastic stabilization. We got around 70 Newton centimeter of torque, and B&B temporary abutment. Implantology has made simple because of these all things which are available in this kit with B&B. And this we take impressions into the laboratory, and within a few one day I think this patient restored, and the patient got this temporary abutment on the acrylic bridge is there, acrylic crown is there, and then we just uh, fix with the hand. Right, so because we got initial torque of around 70, we really need not to worry about whether you are going to move the implant with hand. It's not impossible that you can move the implant with the hand, so you can comfortably screw with the implant, and your crown is stabilized. This is after 1 week when the patient come. We have good healing happening here, and this is after 3 months. And this is what my basically I like my dual zone grafting. I get always stabilize the buccal tissue. I always have a nice buccal counter with the graft material of choice, xenograft, and we have very nice soft tissue around the implant, even though these are acrylic crowns, but the healing is very nice. Right, so finalization, and this is the final crown in position. Right, so in this is my old case in 2007. Patient comes from US. This is 2017. Right, so this is 2017 case. This is day one when the patient. Now this is the case we had given the final prosthesis in 7 days. Now immediate loading we do, and we do give final prosthesis within 7 days. And the last case today I will show you, we had done immediate implant placement on B&B implant in 5 days. Right, just 5 days. So this is a 7 day case. Right, so first day we evaluate, plan, discuss. Day two we go for flapless implant placement. This is a absolutely flapless implant placement. So 4 implant. Immediate loading means 1 implant. If it is possible to place more, I always go for it. Right, so 4 implants. Right, so we achieved fantastic stability because of the apical threads, and these are subcrestal 4 implants, perfect position. Right, so these are 4 implants. Absolutely, we engage the floor of the sinus. After this is the day three when the patient comes for impression. Right, so we take a splinted impression. Impression goes to the laboratory, and day six we get a trial. These are titanium lightweight metal trial. These are titanium based crowns, and very lightweight, absolutely very lightweight. So we are going to reduce the occlusal overloading on the implant. And this is on the seventh day, screw retained, and this is the lingualized occlusion what we had given, and we had fixed on the seventh day. Immediate loading with final crown within 7 days. Right, so this is another case we'll see, and this is I think that I published this case on my ICDR Dental Implant Institute page, which got I think thousands of like all over world. So for the viewers, again, this case is beautiful case. Compromise, old lady, we had gone for immediate implant placement and loading in the mandibular anterior. Right, so I being periodontist, I try to save the teeth, and this patient went everywhere, and she was suggested to go for all and four, but we could save 14 of her teeth and manage with just 5 implants in this patient. Right, so these are 3 implants. Right, so and subcrestal implant placement is very important. Try to match the placement of the implant in one level whenever possible. That is also very important. Then the maxillary, we did crestal approach sinus grafting. Right, so we need to just perforate this sinus floor, and then with the help of a bone expander from B&B we place this implant. You can see this beautiful position of this bone around this implant. Right, so this is absolutely simple procedure to do crystal, but in this case we are not grafted, we just lift the sinus floor, and then one more implant in the mandible. Right, so this is what we take impression goes to laboratory. We give the temporary titanium abutments to the laboratory, and the laboratory sends us this screw retained temporary bridge which we fix in the patient's mouth. Then patient goes back, and after 3 months the patient is ready after the preparations has been done. In my practice, I enjoy doing implant surgery as well as implant prosthetics also. So I have total control on my case, right? And then this is the situation where we do a complete full arch impression. Then we get zirconia crowns from the laboratory, and then this is how we had gone and cemented. And the maxillary, we are gone with an ovate seat preparation here because it's an aesthetic zone. So we have done some preparation of the soft tissue to receive the bridge. This is an ovate seat preparation, and then we take maxillary, and this is how we cemented the maxillary bridge. And this is what you get, a beautiful soft tissue profile around the implant, right? And as an periodontist who has evolved into implantology and further evolved into implant prosthetics, I am really happy that from last 30 years, what new skills we adapted, what new material we adapted, we always kept learning, and today we can give amazing results to our patients. And it is only possible if you keep on learning new and better skills and understand about new material. So this is before, and this is after 4 months, beautiful aesthetics given to the patient. Right, so I will go for the last case, which I think we got to finish in next 5 minutes time. So this is the last and beautiful case, my dear friend. This also I published from ICDRO Dental Implant Institute page, which has been liked globally. Thank you very much for your appreciation. So this patient came from US, and he was here for a week, and he says, doc, can you do next 5 days, can you do final prosthesis? I said, yes, we can give you final prosthesis within 5 days on the implant. We got beautiful implant system which we introduced and which can deliver you the best. So day one, we go for the cbct, right? And CBCT tells me that you have around 8 millimeter of horizontal bone. You got around 9.14, means around 10 millimeter of vertical bone is there. So that is adequate. So I said, yes, your bone is good and we can go flapless. Right, so day one, we start doing a flapless procedure. We place the implant. Right, so this is a 3 millimeter punch, and this is an absolute flapless approach. Very minimum anesthesia. This patient, we are not used more than 1 cc of local anesthesia. The whole procedure happened within 20 minutes or so. Right, so flapless, we need to do not to open the flap, and then we go for a guide pin. We see the position, this is good. Go for the gradualizing drill, and then go with the B&B bone expander, right? So this has made all the difference. We use 3.5 and then subsequent 4 millimeter of bone expander, and then when we went almost 2 millimeter into the sinus, right, lifted the membrane. And this is a B&B EV implant, 4.5 by 10. And my dear friend, we got a torque of around 70 Newton center, right? So that is an amazing torque because of this apical blade. This is the beautiful B&B EV implant. This is fantastic, So I think most of the implantologists, if they enjoy implantology, if their passion, this picture will be very stimulating, and you will be very happy to see something like this. So flapless bone is implant is getting inserted, and blood is going on the surface of the implant. Right, so 70 Newton centimeter of torque has been achieved, and this is the implant. Right, subcrestal implant, least amount of trauma. This is a perfect implant position. Then we place the peak abutment. Right, day two, we call the patient, prepare the rest of the teeth, and they take an impression. Right, this is day 5. Right, so as I promised that we can get amazing results with B&B peak abutment, and I'm really happy to see something like this. Day 5, perfect healing, absolutely very nice soft tissue epithelialization, down growth is there. You can see this unhealed epithelial tissue. And this is an amazing view that suggests us that if we go for less amount of trauma, if we go minimalistic, if we have understanding of the soft tissue, we can achieve a very good healing with our implant and the abutment. And this is day 5. Already we cemented these crowns. And then this is day 5, what we get given the final crowns. Right, so this is very inspiring, this kind of journey for me. When we started learning implantology, we had absolutely nothing, and then now we see over 27 years of my implant practice with multiple implant system. Now incorporation of B&B implants, my practice has absolutely become peace of mind. The success rate is going above 99%. Patients are very happy, and we are able to deliver something like this, which is absolutely we cannot imagine few years before. So 5 years implant, 5 years, 5 days we can do uh, final restoration, and I'm really motivated to do better and better in my clinical practice. So this is what you can see, fifth day final restoration, and patient has gone to the US, and patient is absolutely comfortable with this kind of prosthesis. So my take home message to my all friends, I'm not here for teaching, and this is a wonderful platform what BNB has started. Really thank you for BNB team, Ellie and Simone and all the friends there, Marco and everyone are doing fantastic job. We are sharing our experiences globally, and this is very important in modern time. When we share, we motivate people, will give them the right kind of message, the implantology grows, and that is what is the objective of all of us. So take home message is immediate implant placement is a predictable procedure. Only thing you need to understand all the skills. So it's a technique sensitive, you need to understand the bone and soft tissue and multiple skills. Understand bone remodeling, bone graft, implant design, your surgical drills. Right? So we all need to look our drills very closely. We need to see implant design very closely, and then we can enhance the success rate. Immediate loading can be done if you achieve 45 Newton centimeter of torque, and possibly every case what we do with BNB implants, we are getting this kind of torque. Then B&B implants are top quality implants, and companies driven to give best innovation for our practice. And I like about all my friends from Simone and all of you are doing wonderful job, and new we are very enthusiastic to spread the message that B&B has a top class innovation, and your innovations are going to change our practice. So thank you very much. Keep innovating, and that will help us in the practice. This is my website of the institute where we teach implantology from basics to the advanced, to the beginners, intermediate, and advanced. And we plan to do a lot of courses between the Europe and India. So we definitely, all my friends, we will meet sometime in the future. And this is the page which is getting very popular globally. So go on ICDRO Dental page on the FB and be a friend, like it, and possibly we will be sharing good cases here. Whatever cases we learn here, whatever type of things we are learning from our experience, will be very happy to share. And friends, we in touch. This is my email ID. So Vijay L Deshmukh at gmail.com. This is my email ID. And just send me your questions by email, and I will be able to answer your questions on email. So Vijay L Deshmukh at gmail.com. This is my email ID, and I look forward for some questions on email, and possibly I will be able to answer your questions. So thank you very much, BNB, for giving me this opportunity to speak to you on this BNB Europe and Asia webinar. Right? Thank you very much. We meet next time for sure. Thank you. Bye.